Good afternoon, everyone. Welcome to our program entitled Exchanges Under Healthcare Reform and Private Exchanges, What Does My Nonprofit Need to Know? My name is Jeff Tenenbaum. I'm the chair of the Nonprofit Organizations Practice here at the Venable Law Firm. Welcome to our program, which, as many of you know, because many of you are repeat attendees, is part of our monthly series on nonprofit legal issues that we do here at Venable every month, and welcome those of you who are on the telephone and the webinar across the country joining us here today. We have a nice crowd, about 50 people in the room today, and we have close to 200 people signed up and participating via webinar today across the country. This is a very hot topic right now. Obviously, that's why you're here, presumably. This is a topic of great importance to all employers, including nonprofits. It's a topic that's not only very important, but it's also incredibly confusing. There is a real lack of information out there about this topic, yet it's so important and it's going to have so many critical implications for nonprofit employers and for-profit employers that we felt it was very important to add this to our mix of monthly programming and deliver a program here today on this topic, and in part because we're fortunate to have some terrific expertise in-house at Venable who are real experts on this topic, one of whom is here with us on the program today, and an outside panelist as well. Our two speakers today, first to my immediate right, Chris Condalucci is of counsel here at the Venable Law Firm. Prior to joining Venable, Chris served as Tax and Benefits Counsel to the U.S. Senate Finance Committee from 2007 to 2010. As Tax Counsel to the Finance Committee, Chris actively participated in the healthcare reform debate and the development of the new healthcare insurance exchange. Chris was literally in the middle of the mix when this law, the Patient Protection and Affordable Care Act, was written, is a real expert in this area, has been a real value and benefit to our nonprofit and for-profit clients here at the firm, and we're fortunate to have him as part of our program today. To Chris's right is Alan Cohen. Alan is Chief Strategy Officer and co-founder of Liaison and leads the development of Liaison's award-winning Bright Choices Exchange. Previously, Alan was the CEO and co-founder of Online Benefits, a benefits management and communications technology firm, and he also worked in the insurance industry for Prudential, MassMutual, and Cigna, and managed an insurance brokerage. Liaison is a private exchange itself, and we wanted to have Alan here to really help walk you through some of the nuts and bolts of private exchanges and how they work and what are some of the pitfalls and what are the advantages and disadvantages and what should you look for. And I think the combination of Chris and Alan here today is going to make for a really terrific program. We have full speaker bios in your handout materials. Your handout materials also contain a couple one-pagers that Chris put together that are some really helpful summary documents on this topic. Some logistical issues for today. Questions. What we're going to do is Chris is going to speak first and then Alan. We're going to take questions at the end of each of our speakers' presentations since they really are distinct presentations on today's topic. So save your questions. When Chris is done, we'll take questions. For those of you in the room, raise your hands. We'll answer your questions. We'll repeat those for those on the telephone. For those of you who are on the phone, pose your questions using the chat feature on the webinar software, and I'll pose those to our speakers at the appropriate times. Handout materials, those of you in the room have a printed copy of the PowerPoint slides as well as Chris's supplemental resources. Those of you on the phone should have gotten an email. Link to the PowerPoint presentation and all of the resources will be emailed to you tomorrow. As you know, a follow-up email will go to all registrants tomorrow. That will also contain a link to the recording of today's program. Feel free to pass that on to colleagues and others who might be interested. Preview of a few of our upcoming programs. We actually have 3 programs scheduled so far for next year for January, February, and March. 3 really interesting and exciting topics, at least from my perspective. January 8th, our program is going to be entitled Exempt or Non-Exempt, the 10 Most Common Employee Classification Pitfalls Faced by Nonprofits. On February 12th, our program will be entitled Top 10 Federal Grant and Contract Pitfalls for Nonprofits. And on March 12th, guess again, another top 10, Preparing an Online Social Media Policy, the top 10 legal considerations for your nonprofit. If you couldn't tell, I'm a fan of top 10 lists. But actually all 3 very distinct, different, but very, very interesting and important topics, and I hope you'll join us for those programs next year. Finally, links to all of the recordings of our nonprofit legal seminars dating back almost 2 years now can be found on our website at venable.com/nonprofit/recordings. That link is found on the last slide of today's PowerPoint. And all of our articles and PowerPoint presentations and other resources on nonprofit legal issues, probably close to about 750 or more documents at this stage, can be found at venable.com/nonprofit/publications, and you can search for those by topic areas. I want to thank Pat Reed, who's been filling in, doing yeoman's work for Jamie Fitzsimons from our marketing department, doing a terrific job helping put these programs together. And with that, I'm going to turn it over to Chris to get us started. Chris?
Good afternoon, everybody. Thanks for everybody for joining us for lunch today, and thank you for those who are on the phone for joining us as well. As Jeff indicated, we do have a very interesting topic, or shall I say topics, plural, to discuss. Certainly timely. The election obviously indicated to practitioners, to stakeholders, to employers who are offering health insurance coverage to their employees that the new health care law is not going anywhere, at least anytime soon. So again, it's certainly a timely topic, which is why I want to go ahead and start talking about the exchange as created under the health care law. So for purposes of talking today, I'm going to refer to it as the public exchange, because part of my presentation, I will also touch on private health insurance exchanges, really from a high level or a higher level, because Alan Cohen here, who actually operates and works for a private exchange company, will actually get into detail of how a private exchange actually works. So I didn't want to have much overlap when it comes to my comments about private exchanges. Instead, I want to focus on the public exchange, which, again, both topics, very timely. A lot of people are asking, what are these public exchanges as created under the law? How will they impact me as a small employer? How will they impact me as a large employer? And there are different impacts, whether you're a small employer and a large employer, which we're going to discuss. But then there are these other creatures or entities out there which are private health insurance exchanges, which were in existence even before healthcare reform, which again, Alan will get into further detail on. So without further ado, let me jump right into the presentation. Now, as Jeff indicated, my background, I served as tax counsel to the Senate Finance Committee during healthcare reform. Now, one of the cool things about working for the Senate Finance Committee is I was on the Republican side. I worked with Senator Grassley. And Senator Grassley and Senator Baucus, chairman of the Finance Committee, have historically worked very closely together for the past 10 years, for example, or about 11 years. Senator Grassley is no longer ranking member, Senator Hatch is. And the reason I say that and why I enjoyed being on the Finance Committee and Senator Grassley and Senator Baucus working so closely together is in January of 2009, the Baucus staff and the Grassley staff, we sat down together and wrote what we thought healthcare reform should look like. And we worked together on a bipartisan basis from January of 2009 to September of 2009. And a lot of, I would say, the foundation or a lot of the core aspects of what you see in the final end result of the law that is now the law was really born in those Finance Committee discussions. When the debate went partisan in September of 2009, I was no longer, my colleagues were no longer at the drafting table. So there were some twists and turns that were made to the law that arguably wouldn't have been made in a more bipartisan exercise. But at the same time, a lot of the foundation that we discussed did make it into the law. And one of those core features was the public exchange. So I had a significant amount of involvement in developing the public exchange while on the Finance Committee. And, we looked to the Massachusetts connector. We looked at private exchanges, for example, when structuring it. We obviously now see the structure of the exchange because the law is now the law. But I just say that as some background based on my experience. So I'd like to start with this first slide because based on my experience, there were really two drivers to healthcare reform. The one was the drafters of the law wanted to reform the insurance laws. And what I mean by that is the drafters of the law felt that there were insurance policies out there that didn't provide adequate enough coverage. So as I like to refer to it, the drafters felt that there was policies that didn't provide the right coverage. So one of the ways the drafters accomplished policies offering the right coverage is they incorporated minimum standards into the law. And we've heard about all these minimum standards. Complex. We could probably talk about each of these subjects for 2 hours respectfully, but the minimum standards include the essential health benefits, cost-sharing limitations, the actuarial value. So that was one of the drivers of healthcare reform. The other was, and in my opinion, based on my experience, was priority number one was expanding access to coverage, so expanding healthcare to all Americans. And the way in which the drafters accomplished this was expanding Medicaid, the largest expansion of Medicaid in history. Now, the Supreme Court obviously had something to say about the expansion, and there's a lot of question of whether states will expand Medicaid coverage, and we just heard HHS indicate to the states that it's really an all-or-nothing proposition with regard to expanding Medicaid, which I think will have an impact on whether a state actually does decide to expand. But that was one of the drivers, at least Congress expanded Medicaid. The other driver, which is relevant to our topic today, is the drafters wanted to subsidize low and middle income individuals to purchase insurance because there was a belief of, okay, those folks that are above Medicaid eligibility, they still can't afford insurance. So let's try to help them out. So this premium subsidy or advanced refundable tax credit, which again is really a subsidy, was created. Now the delivery mechanism for this premium subsidy is actually through the public exchange. Now what's interesting though is, which leads me to this slide, the original intent of an exchange wasn't to deliver the subsidies. The exchange, it's a marketplace. So the concept of an exchange is a marketplace. And really, this concept of exchange has been around for 20 years now. I mean, it was debated during Hillary Care. The Heritage Foundation created a framework to which then the Massachusetts Connector, which was generally based on, it's taken some twists and turns since then. But this concept of an exchange, of a marketplace, has been around for a while. And in the interest of expanding access to coverage, we as drafters in Congress gravitated toward this type of mechanism. And there was a belief that if you create this marketplace, it reduces administrative costs. If you have multiple carriers, it might promote competition and the age-old adage of, more competition, lower premiums. So it was believed that at the end of the day, we might have more affordable coverage. Now there's question whether we're going to have affordable coverage going forward based on some of these minimum standards that have been incorporated into the law, and then some of the other fees associated with taxes and user fees and things of that sort, which we'll get into in a second. But that was at least the original intent. And it's interesting, as I indicated early on in the drafting process, we actually wanted to model the exchange structure after private exchanges, not the Massachusetts Connector, which generally is the model that you see the exchange as envisioned under the law modeled after, more of a Massachusetts Connector, a bit more of a regulatory body, which leads me into this slide, or these next couple of slides. So the public exchange is created under the law. There's really two of them, two types of public exchanges. You have the state-based exchange, and you have the federal exchange. Now, everybody has read in the news, with regard to states setting up state-based exchanges and the feds coming in to set up exchanges for those states that don't want to set up exchanges or aren't far enough along in the process. But I want to first start with the state-based exchange, right? Because the law really intended to encourage states, or at least the drafters, we always believed that states would set up exchanges. We didn't think that there would be this level of resistance to exchanges when this law was being drafted. So state-based exchanges, how are they structured? Well, first, they're only available to individuals in the individual market. And when I say available, insurance being sold through this marketplace will only be sold in the individual health insurance market, as well as employees of small employers in the small group market. Now, I stress this, which I think most folks now know, is because large group, if you're a large employer, you're not participating through the exchange, or you're not buying health insurance coverage through the exchange. Now, in 2017, there is a provision under the law which allows a state to allow large group coverage to be sold through the exchange, but a state doesn't have to do it. And obviously we're not at 2017 yet. So it's important to just understand the core concept: individual market, small group market, only type of coverage that can go through the exchange. Also, another very important concept: this is the fully insured market. So obviously, by definition, if you're in the individual market, you're fully insured. But in the small group market, there are some small employers out there that do self-insure. Even those small employers that self-insure, self-insured plans are not offered through the exchange. They are not offered through the public exchange. And even if a state were to elect in 2017 to allow large group plans to be sold through the exchange, similarly, that will only be a fully insured product. It will not be a self-insured arrangement, which, as we all know, larger employers are the more likely to self-insure. At least the larger of the larger employers are certainly more likely to self-insure. Now, this last bullet on this slide is also important because it somewhat relates to private exchanges. The exchange can only be structured as a governmental agency or an independent nonprofit entity. Now, most states that actually are setting up a public exchange are going to a quasi-public-private entity. So it's not quite a government agency, but it's certainly not quite a nonprofit entity. It's something in the middle. So that's really where states are going with structuring their exchange, which differs entirely from a private exchange. A private exchange is a for-profit endeavor. You cannot be an exchange as contemplated under this law if you are a quote-unquote private exchange, which is why they're separate and distinct and why we have two topics that we're discussing today. So this next slide, what does a state-based exchange have to do? Well, it has to do a whole heck of a lot of functions, and arguably it's a bit over-regulatory with respect to the type of responsibilities that the state-based exchange has. It ranges from determining Medicaid eligibility to determining whether somebody is eligible for a premium subsidy. A state-based exchange is required to set up a call center to field questions from people who have questions about the qualified health plans that are being made available through the marketplace, website, and in some states, excuse me, the statute does allow the exchange to kick out a carrier if it feels that that carrier is increasing rates of a particular plan unreasonably. So right now, we don't see many states gravitating toward this or vesting this type of authority in their state-based exchange, but the provision is in the law, and at some point we may see a state-based exchange being an active purchaser. I mean, California, you can argue, is an active purchaser. Some folks are questioning whether Massachusetts or Maryland or Connecticut or Colorado will be. That still remains to shake out. But the bottom line is, this is permitted if a state decides to vest this type of authority in its state-based exchange. So, as I stated, there's two types of public exchange. One is the state-based exchange, which we generally just touched on. The other is the federal exchange. As stated, when we were drafting this law, we put in a federal fallback because really we believed that some states just couldn't get their act together. But they arguably would get their act together at some point. Some states have their legislature that meets every other year, for example. So we had a federal fallback that said, well, if you don't get your act together, at least the feds will come in. Again, we never expected there to be this type of resistance. To an extent, now the administration, now that this is in the hands of the regulators, the Department of Health and Human Service that is, they realized fairly early on of, oh my goodness, we're going to now be operating a significant number of exchanges in a significant number of states. So what do? Well, interestingly though, even with this federal fallback, we didn't envision it to be the entity that it's now kind of turning out to be. We always intended the federal exchange to step in the shoes of the state-based exchange. So for example, all of these functions that are here for the state-based exchange, the general matter, federal exchange is going to perform. That's what Congress always intended. Now, the statute doesn't quite say that, and there's some question with regard to the statute. As we all know, drafting legislation is a very complex and very difficult process. Oftentimes there's mistakes, errors, omissions. We actually have one in the law where there is now question whether a federal exchange can deliver this premium subsidy that I described at the beginning, and I'll touch on it in more detail in a moment. So that all remains to shake out as well. But I would argue that the federal government that's going to go into a state that has said, HHS, you run my exchange because I don't want to run an exchange or I'm not ready to run an exchange, they're going to deliver the subsidy. So even though there's this argument of whether the federal exchange can deliver the subsidy or not, the administration has said that they have the authority to deliver it, and therefore when they go into the state come 2014, provided there's no extension, which again we can talk about later, the federal exchange will be delivering the subsidy. At least that's at this stage of the game at 1 o'clock on December 11th. This next slide, federal-state partnership. I've heard this being discussed. Really, this falls under my second category, which is federal exchange. So really, this is just a subset of the federal exchange. And really, when HHS realized that, again, they were going to be operating so many exchanges, or they realized that states weren't going to be able to get their act together to get their exchange up and running by the arbitrary deadline set forth in the statute, they said, well, let's just share the functions. So the feds will take on 5 of the functions, that I have here, and you state you take 5 of the functions as well. But then they even dug into that a little bit more to say, okay, what's more appropriate, or what's most appropriate for the state to take over from a functions perspective under this state type of partnership? Well, one is plan management functions, essentially determining whether a health plan can be offered on the public exchange or not. And that makes sense because the Department of Insurance does that every year with the carriers who operate within that state. Consumer assistance, same thing. Boots on the ground, you know your constituency as opposed to the federal government. So that certainly makes sense. But the federal government will take on some of the other responsibilities, which also generally makes sense. It's a little more federal-oriented, Medicaid eligibility determination, determining whether somebody is eligible for the subsidy, management of the website, call center. So that's the federal-state partnership. So here are some important deadlines. So we have December 14th. And actually, this was a deadline that was recently extended from a November, an earlier deadline, which HHS said to the states, look, if you want to set up your own exchange, you got to let us know, and you've got to submit this blueprint that HHS also came out in guidance, kind of giving the state kind of a blueprint, a contract for them to fill out, explaining, how their state-based exchange is going to work. So that's December 14th. One will argue that that's still a soft deadline, but nonetheless, it's a deadline. February 15th, another deadline that HHS threw out there. And this goes to the federal-state partnership that I just described. So if a state wants to do the federal-state partnership, they have until February 15th to do that. Now, here are the 2 real important dates, which is why I wanted to include this slide. October 1, 2013. That is when open enrollment begins. So that is when, let's just say I'm not working for Venable. Let's say I'm a sole prop or I'm someone who's unemployed, and I'm an individual purchasing insurance in the individual market. Well, October 1, I am able to go to a state-based exchange or a federal exchange and enroll in a health plan. That's the target date. Now, there's a lot of question of whether states are going to make it for those states that want to set up their state-based exchange. There's question of whether the feds are going to make it with the federal exchange. Of course, the administration and those folks at HHS are going to say, we're on track. We are going to hit the deadline. Of course they're going to say that because they want to keep folks in line until they're going to say, uncle, and we can't do it. That, in my opinion, won't come until closer to an October 1 time frame. But at least that's what they're saying. So, again, in fairness, let's take them at their word, that October 1, folks will hit it. January 1, 2014, another important date. Subsidies are going to start flowing. Or really, the exchanges are supposed to be up and running, which really marks the flowing of the subsidy. Then there's also a question of whether these subsidies will flow adequately and efficiently and accurately, because there's a whole host of information technology, infrastructure, and architecture that needs to be created in order to determine whether somebody is eligible for the subsidy. And from information that I'm getting from the private contractors out there, yes, they might be able to hit the January 1, 2014 timeframe, but they're behind schedule with regard to putting these IT systems together, implementing them, and testing them to work out all the bugs to make sure it works. So there's even some questions with the subsidies. But again, let's all assume that it's going to flow January 1, 2014. So here on this slide, what have the states decided? We have a whole host of states that have said, feds, you do this. We do not want to run an exchange. Or they have also said, uncle, that we're just not in a position to set up our exchange. The second category is the federal-state partnership. There are some that actually have said, we're going to do federal-state partnership. There's another category who's undecided. One would argue at this stage of the game, they're probably going to fall into the Category 1 federal exchange, but they could very easily do a federal-state partnership if they wanted to, because, again, based on the deadline, you have until February 15th. And then Category 4, these states are the trailblazers, as one would like to refer to them. They've said, we're setting up our state-based exchange. We're going to be ready to roll October 1. So important for Category 4 for everybody in the audience and on the phone to understand. If you're in these states, you are arguably going to be able to go to your state-based exchange, and you are going to be dealing with the folks within your state. If you're in Category 1, if you're in a state that operates there, or you have pieces of your business that operate there, you are in the federal exchange. And again, this is individual market and small group market, so one would argue how many small employers are operating in a whole host of states, but you might have a situation where, let's just take the District of Columbia, notwithstanding the fact that D.C. is setting up their exchange, notwithstanding the fact that Maryland is setting up their exchange, I might be a small employer in Virginia, or I might have businesses there, or I might have employees that live in Virginia but work in these other areas. There's some complicating issues relating to that I wouldn't even say need to be fleshed out, but certainly are beyond the scope of this presentation, but they're issues. So challenges, I touched on them. Information technology is something that needs to be implemented, tested, et cetera. Well, there's a shortage of vendors in the IT space, and there's a whole host of states that arguably need to do this. Also, there's a lack of guidance. As we all have heard, folks have complained to the administration, we've not seen guidance. And to an extent, to me, it's not political, it's practical, because you do need the guidance to get these entities propped up, to coordinate with the insurance carriers who are going to sell plans through this marketplace. And it's interesting, the NAIC just had a conference about a week and a half ago, and the Nevada Insurance Commissioner, Nevada being one of the states that are going forward, quoted, said, we're going to make it, I think it's going to be tight. So that just underscores the fact that it's going to be close. There's a lot of question, and one of the reasons why they're having these challenges is for these two reasons. Now, I want to touch on the subsidies for health insurance because they're very important. They are arguably a driver for behavior. Again, the subsidies are only available in the individual health insurance market. So if you are a small employer and you decide that you want to play with the public shop exchange, you will not have the premium subsidy that is set forth in the law. The only thing that's available to you is a small business health insurance tax credit, as it's referred to, which folks may argue is limited in size, or at least I would say from a monetary perspective, from a benefit perspective, but also it's temporary. It's only a 2-year tax credit when the shop exchanges are up and running. So back to the subsidies, though, because they are important also to large employers. So the subsidies are only available to individuals in the individual market, and the only place you can get them is through the public exchange. Now, the final exchange created what is called web-based entities, which can be a private agent and broker, for example, that can welcome a consumer and direct that consumer over to the public exchange to access the premium subsidy. Again, these web-based entities are beyond the scope of this presentation, but there are rules that are there. So if you have questions on that, feel free to follow up. I'm happy to answer them. But again, subsidies, individual market, only available in the public exchange. Not available to small employers, certainly not available to large employers. But there's an exception to the rule, which is going to segue us into an issue for large employers. Under the law, there is a rule called the employer mandate, which I think most folks in the audience and on the phone know by now, actually affects employers of really 50 full-time equivalent employees. So you can be an employer with 30 full-time employees and 100 part-time employees, and you aggregate them all together to determine whether you're above this magic 50 full-time equivalent threshold. But for simplicity's sake, let's just say you're an employer of 55 employees. Well, you're subject to this employer mandate. Obviously, if you have 5,000 employees, you're subject to the employer mandate. And the employer mandate, which again I'll touch on in another slide, essentially says you have to offer coverage or you're subject to a penalty tax. But there's a second rule, and somewhat of an exception to this subsidy rule that I just described, which says, okay, employer, if you're offering coverage, your coverage has to meet certain minimum standards. And those minimum standards are, one, it has to be affordable, and two, it has to provide, quote unquote, minimum value. So it's related to this minimum standard that was incorporated in the law as I discussed on my first slide. Now, if you're an employee working for an employer subject to the employer mandate, and your coverage is unaffordable or it does not provide minimum value, you can opt out of that coverage and you can go to the exchange and get the subsidy. So again, why I'm emphasizing this slide. Generally speaking, the only people who can get subsidies is individuals in the individual market. Basically, people who are not getting offered an employer-provided plan. But there's an exception to that rule, which is if coverage is unaffordable or it doesn't provide minimum value, you can opt out, bam, go to the public exchange, get the subsidy, provided you're income eligible, of course. So, small employer interaction with the public exchange. So if you're a small employer, obviously pay attention to this. If you're not, you don't quite have to worry about this one. You'll have to worry about my next slide. As I indicated, public exchange, small employers can play in the shop. Now, it's important here that generally the law changed the definition of small employer. Generally, under the law, small employer is defined as 1 to 100. Now, there's a special rule under the law which says between now and 2016, a state can decide to keep its current definition of 1 to 50. And most states are doing that. Most states are keeping their definition of small employer, which then determines whether you're in the small group, to 1 to 50. And the reason is they realize that there's enough disruption that's going to occur under this law. Why add to it? So they're going to wait until 2016 until the law forces the state to redefine its definition of small employer. So I emphasize that in 2016 it's not an option. Small employer, 1 to 100. Now, with regard to the shop exchange, how does that work? Small employers must be able to send their employees to the exchange, and their employers can pick a metal level, and their employees can choose whatever plan or whatever carrier makes available a plan in that metal level. So that's what the law says. And the guidance that just came out relating to the federal exchange actually adopts this rule for the federal shop. It says an employer, you pick a level, you would let your employees have at it among all the carriers and all the plans that are at that level. So that's important. But there's some flexibility with regard to how a shop exchange can be structured. And to my knowledge, the federal exchange has not yet adopted these options explicitly. They've only adopted that general rule that I just described. But these options are a state can say to its shop exchange, the employers that want to play with you, their employees can do anything they want. They can go to any meta level, any carrier, any plan. And that's up for the state to decide whether its shop exchange will offer that type of option. The other is the employer selects like 4 different plans from a specific meta level. So I'm a small employer. Let's say I'm offering pretty rich coverage today. I find that silver or gold is comparable to the rich coverage that I provide today. I want to send my employees to the shop. I say, employees, you can go to the gold level, and I'm picking 4 carriers or 4 plans within the gold level that you can go to, which is almost similar to what we do today, or what's done today, but that's another option that a state can vest in its shop exchange. The other is the employer could just pick a single plan, which again is most common in the small employer context. That is an option that a state can vest into its shop exchange. Now, we don't yet know where the states are going to go with this, or at least I haven't seen specific guidance from some of the states on these points, but these are all important points I think small employers should know as it relates to interacting with the shop exchange. Now, let me touch on this because I want to finish this to give plenty of time to Alan. There's a question in the audience?
Yeah. So if you're under 50 employees and you're in DC, you have to go to exchange.
Oh, that's a very good question, and I was waiting for it. So the question that the gentleman asked is, in DC, do I have to go to the exchange? And right now,
if you're an employer under 50.
Yes, if you're an employer who is in the small group market, which as far as I know right now, DC wants to maintain the definition of small employer from 1 to 50. So if you're a small employer, 1 to 50, the question is, do I have to go to the DC shop exchange? And there is a recommendation on the table that says we are eliminating the outside market. That is DC. So DC is making its exchange, as I like to refer to it, the only game in town. Now, I have an opinion on this, especially based on my experience drafting the law, that I would argue that there is a legal argument that DC cannot eliminate the outside market. The statute to me is fairly clear that it contemplates an outside market. And then you might also have a McCarran-Ferguson preemption issue, which again is beyond the scope of what we're going to talk about today. But to your question, DC has said the only game in town is the exchange. So if that recommendation is passed by the DC Council and put into DC law, then if I'm an employer of 1 to 50, small employer that is 1 to 50 in DC, I can only go to the shop exchange. Most states aren't doing that. DC and Vermont are really the only 2 that I've heard who are contemplating eliminating the outside market and making the exchange the only game in town.
So if you're under 50 employees and it's determined that you have to go to the exchange, so you would go to shop and essentially form a group plan under the exchange. Now, if you're an employer that has under 50 employees and you just say, I just want to get rid of healthcare altogether, then how does that work? Your employees, which are probably in Maryland, DC, Virginia, do they go to the Virginia Federal Exchange, Maryland State Exchange, if you just don't deal with healthcare altogether? Is that how that works?
Yeah, so the question is, if that small employer in DC just decides to drop coverage, what happens to those employees? Well, A, if you drop coverage, they're in the now individual market. And I would argue, and because this hasn't been fleshed out, but those individuals, where they reside is the state that they would be purchasing insurance in, which is different than if you're the small employer in the small group offering in DC. You're offering coverage in DC. So therefore, even if your employees live in the other jurisdictions, you're governed by DC law. But if you're to drop coverage, then My response to that question would be those individual employees, depending on where they live, can go to that state exchange or federal exchange or outside market in the individual market, because those states have maintained that outside market outside of the exchange. But if you're in the individual market, not many people are going to go to the outside market because the subsidies are available in the public exchange in the individual market. And if you're income eligible, you're going to gravitate toward that. I mean, if you're not income eligible, maybe you go to the outside market. So I see there's another question.
If I drop the coverage totally as an employer, I get a penalty, correct?
The question is, if I drop coverage, I'm subject to the penalty. And the answer is, it depends on how big you are. As I indicated, if you're 50 full-time equivalents and higher, yes, if you drop coverage, you'll be penalized $2,000 times all of your full-time employees. That's the no offer penalty under the employer mandate. So again, I'm 50 or more, I drop my coverage, one of my employees goes to the exchange and accesses the subsidy, I'm subject to a $2,000 penalty, the employer that is, $2,000 penalty times all of my full-time employees.
For that individual?
For that employer. So if I'm employer A, I have 55 employees, and I drop coverage. One of those 55 employees goes to the public exchange, gets the subsidy. I, as the employer, are subject to a $2,000 penalty times those 55 employees, assuming those 55 employees are full-time employees. So that's why I went to law school. I'm not a math major, so I'll let you guys do the math. But if you're under 50, if you're 25, you can drop coverage and you are not subject to this penalty.
Currently and throughout the dates that you project where the plan will be implemented, state and federal, there are a number of people covered under COBRA. How does that figure in?
The question is, how does COBRA coverage fit into this? And my response to that would be, and I honestly haven't looked into it, is COBRA would still be considered a group health plan. So to me, that would still be considered an employer plan, and therefore you're subject to the rules for employer group health plans. So for purposes of, let's say, the subsidy for health insurance, if you're on COBRA, you're not going to be eligible for the premium subsidy, because one of the things that the law says is if you have an offer of employer coverage, you're not eligible for the premium subsidy. So I would argue that if I'm on COBRA, that's still quote-unquote a group health plan, and therefore I'm not eligible for the subsidy. Now, when my COBRA time period ends, then I'm thrown arguably into the individual market, provided I didn't get employed during that time frame. Then I'll be eligible for the subsidy.
To follow up to his question about DC coverage and your only game in town comment, what happens if you have a DC employer under 50 employees with a MEWA plan with another employer who's out of DC?
The question is, what if I am a small employer, but I'm in a MEWA in DC? And my response to you would be, and I don't know this, it depends on how DC views your MEWA. Does it view you as large group, or does it look through the MEWA down to the underlying groups? So let's say I have 3 employers, each 25, I'm trying to get to, let's say I have 5 employees, 25 each. And DC law says that MEWA, the aggregation of all of those 25 employees together, puts them into large group. It's out of my definition of small employer. Then you aren't subject to the exchange. You're not subject to this only game in town issue. But if DC law looks through the MEWA down to the individual group and you happen to be 25 employees, then that's a different issue. And again, I actually don't know the answer to that question because I don't know how DC treats the MEWA.
So that there's not a sense on which way they're leaning?
I've not heard anything. And I don't know if anybody else in the audience have heard DC talk about this issue. I don't.
They may completely ignore the MEWA, is basically what you're saying. They might.
It's always dangerous to answer affirmatively, but again, this is just with this MEWA and whether DC is going to recognize the MEWA or not. I don't know. Let me look into it for you, because I think it's an issue. I would guess that DC looks at the MEWA as a large group plan, because a lot of states typically do that. And so if you're large group, you don't have to worry about this only game in town issue.
What if your MEWA partner is out of DC? Then which would you fall under DC law, or would you fall under Maryland or Virginia, wherever you're?
So the question is then what jurisdiction would kind of govern that MEWA? I would say wherever that master policy is written will be the insurance rules that will apply to that plan. One thing about MEWA that's important to know is you have to comply with all the 50 states' rules. So that would be my answer, is if I'm a MEWA in D.C., but I have other folks that are in my MEWA that are in a different state, that either my policy has to meet the rules that are governing an insurance policy within that underlying state. That would be my answer. So to an extent, you're subject to the four corners of the state in which to me, that policy is written, or that, correct. One more question. I want to turn it over to Alan, and I'm not going to even go through my slides because I want to give plenty of time to Alan.
Okay, with the District of Columbia, my experience is people in this area, let's say inside the Beltway, move the same way people all over the country. Every 3 to 5 years, people are moving jurisdictions. And I think, if anything, it's going to be worse in D.C. Because the young people we know are all flooding in. They start their career in D.C. 5 years later, they're married. They're in Maryland. 3 years after that, they want a bigger house. They go to Virginia. Are they going to be moving all these plans around?
Yeah, and the question is, if D.C. is a transient place, so people are moving all around, how the insurance law is going to work there. The way I would answer that question is, if you're an employer who's located in the district, you are essentially subject to the insurance laws that apply in the district. So even if your employee who lives, here in the district moves to Maryland, they're still technically employed by a D.C. employer, and therefore are subject to the D.C. the D.C. insurance laws. Now, most carriers have provider networks in all of the jurisdictions. So for all intents and purposes, you won't be affected, or those employees won't be affected by some of these different insurance laws that apply, or different state-based exchanges or federal exchanges, or the only game in town with regard to where you can buy insurance or not. Because let's play this out. So D.C., you can only buy through the exchange. Well, I buy, carrier Y. Well, carrier Y is arguably going to have a provider network in Maryland. So if I live in Maryland, I can arguably go to that doctor, even though I'm kind of governed by the insurance laws or in the insurance plan that's written in D.C. So I think that's how you deal with it. From an individual perspective, it's individual health insurance. I think then you're subject to the state in which you reside, which differs from the employer setting, which, my understanding, generally tracks where the employer essentially is domiciled, or that place of business, or where it's incorporated. So that's how I would answer that question. So in the interest of time...
Yeah, Chris, before you move on, is there anything you want to highlight from the rest of your slides in 2 minutes or less?
No, because to an extent, a lot of this is in the slide deck, so you can definitely take a look. Really, the large employer relates to the employer mandate issue that I already discussed. So there's some nuances to it. So if you have questions on it, please feel free to let me know. So with that, let me forward this all the way to hopefully pick up Alan's.
Yeah. So there is a lot of information left that Chris was not able to cover, but feel free to take a look at his slides. Also, I apologize to... We got a lot of questions from those of you on the webinar that clearly we were not able to get to in the interest of time. If we have time at the end, we will certainly try to cover some of those. But we knew there were going to be more questions we'd have time to answer, especially on today's topic. But feel free to follow up with us, with any of the three of us, particularly the two experts here after the program. Contact information is at the end, and we'd be at the end of the slide deck, and we'd be happy to help you. So with that, Alan, you want to take it from here?
Great. Thank you very much. It's certainly a topic that could take up quite a lot of time. I'm going to try to go through things pretty quickly because you only have another about 35 to 40 minutes of your time. So I'm going to focus on private exchanges. My goals for today are what you see up here. Give you a little bit of information about who Liaison is, so maybe a frame of reference on why kind of our opinion on this stuff should matter. Talk about exchanges and kind of how to differentiate them, looking at public and private exchanges. Focusing on what the problem is exchanges solve. And then going to what you should expect from an exchange as you think about using an exchange. Frankly, whether it be a public exchange or a private exchange, I don't think it matters. What you should expect from them is the same. And then we're going to use Bright Choices, kind of the exchange that we have as an example of how working with an exchange can work, and what you should expect from an exchange, how the services can work, and what the results can be. So first, just a little bit about who we are. We're a company about 5 years old, so we predate any of the healthcare reform discussions. We were kind of the exchange before people called it an exchange. Actually, frankly, that term itself, I'm not a big fan of that term, although now we are in the private exchange industry. An exchange is a place where you buy soybeans and pork bellies, right? We buy things in stores. Using that terminology, I think it's okay in the kind of insurance world, but as you talk to employees, as you talk to people, I would get rid of that terminology. When we started the company, we started with simpler words, right? We would say a company, an organization, creates a budget for benefits. They then allocate those dollars to the employees and plug their employees into a store where people can buy what they need. They can buy health insurance and dental insurance and life insurance, disability insurance. It's a wide benefit store. So that's now become the defined contribution. That's the budgeting part of it, right? Private exchange or private benefits exchange industry. We're a leader in this industry. Again, it's a good thing to start a company in a place where no one ever started a company before. You can become the leader, right? But it's somewhat tongue-in-cheek, but in the last 5 years, we've brought on over 2,200 companies. Over 50,000 people use the Bright Choices Exchange today. Actually, there's an additional 25,000 coming on effective January 1st. We're now somewhere between 10 and 15 organizations, companies, typically use the Bright Choices Exchange every week. Every week they come on to the Bright Choices Exchange. So we've seen the growth really go up in a very quick fashion. We work with benefits consultants and insurance brokers and health plans and different types of insurance carriers nationwide. And our technology has won a bunch of awards for consumer engagement, for healthcare consumerism and the like. It's impossible not to be confused in this area of exchanges and private exchanges. Just some of the quotes that you see coming out, right? Aon Hewitt launches a private exchange and 5,000 workers or maybe 100,000 people. I'm not sure which one because it's different on different press releases. Aetna releases a statement saying that they're working with Liaison with private exchanges in a couple of different markets. WellPoint buys a private exchange company, Bloom, in order to compete with the public exchange. They actually said that in the press release. It's kind of a shocking thing to say. Arthur Gallagher, Benefits Arm, says that they've signed a deal with Liaison to roll out a nationwide exchange. Highmark rolls out an exchange with Array Health. It's coming at you from all different areas. From the kind of consulting side or from surveys and studies, we have Oliver Wyman that came out with a survey that said that 80% of companies expect to use a private exchange in the future. J.D. Power says 47%. I guess they asked the question differently, right? Only 47% said in one survey, 80% in another survey. I mean, what does it all mean? Frankly, I struggle with this, right? And this is what I do for a living. And so one of the things I try to do, and actually this slide started out as kind of my way to understand what all these exchanges are. And it's a somewhat simplified version that now I'm kind of using to help other people decide and figure out what these exchanges are. So hopefully, this is actually something you can use in the future as somebody comes to you with a private exchange. You read about it in an insurance periodical. You can kind of use this called rubric to kind of understand what this exchange is all about. So how do we sort it out? I think the first thing you want to ask the question is who runs it? Is it a public exchange? Chris talked a lot about really two public exchanges, the individual exchange and the shop. In fact, it's multidimensional. It's going to be the HHS one, the combination ones, the state ones, individual and shop. So the public exchange is run by the government, right? Private exchange is run by private enterprise, again, like Liaison. Then I think that you're going to see starting 2014 this idea of hybrid exchanges. Exchanges that really are, in essence, private exchanges that in some way access products that are on the public exchange. This gets to the point that Chris was talking about, these web-based entities. There is this notion that has now been popularized by the HHS in their guidance that private organizations will be able to access the public subsidized exchange in some way. How it is, who knows, because these exchanges don't exist yet. But it kind of opens the door for this idea of a hybrid exchange, where maybe a group of people come into an exchange and some of them are actually buying insurance off the public exchange with subsidies. Some of them are buying it privately, so it's this hybrid. So I think that's one way to think about it. And the big difference between the public exchange and the private exchange is the public exchange is going to be funded by a lot of taxpayer dollars, a lot of subsidies. Private exchange is there's no subsidies there. The next question you want to ask yourself is what kind of products are in the store? Again, I think it really is helpful to think in terms of language like a store, like people shopping for insurance as opposed to an exchange, which we don't have really a lot of experience with. And so, the first thing you have to ask yourself is what are the products? So what are the types of insurance? Is it individual insurance? Is it group insurance? Is it Medicare? There's the three examples that are out there today. Individual insurance, a company called eHealth.com is one of the largest, probably in history, the largest seller of individual insurance in the history of insurance. They operate an exchange. It's a store. Go to eHealth.com. It's all individual insurance, right? On the individual public exchange, that's going to be individual insurance. Group insurance, by and large, Liaison provides group insurance through its stores. Then there's Medicare. Organizations like Extend Health have run Medicare exchanges for a number of years. So what type of insurance is it? Next question is, what's the store offering? Imagine like the aisles in the store, right? Is there just one aisle? It's just all medical insurance, that's all it is? Or is there maybe a couple aisles? So maybe it's medical insurance, maybe it's dental insurance as well, so it's kind of more broadly health insurance, medical, dental, and vision possibly? Or is it all different types of benefits? Is it medical, dental, life, disability, et cetera, HSAs, FSAs, supplemental health insurance? So how broad is the offering that is available through this store or through this exchange? Then the providers. You almost think of it as the manufacturers of the insurance. Is it an open exchange which has all the different carriers that are available? The public exchange is going to be somewhat like that. Is it a closed exchange? An alternative would be a closed exchange, would be a single carrier. The health plans themselves are coming out with their own exchanges. Likely it's only going to be their insurance products on that exchange. It's probably not going to be their competitors. So you could have a store that only had, imagine like the Apple store, right? You go to Apple store, you're not going to buy Dell there. You're only going to buy Apple. Then a selective exchange, which is not open. It's not every carrier that's out there, but it's maybe a combination of 2 or 3 of the different manufacturers that are offering their products. Oh, sure. The next question is, what's the shopping experience? So the shopping experience, think about location as the first question. You use this old .com language, clicks and bricks. We tend to think about exchanges and talk about exchanges as these things that live in cyberspace and no place else. Frankly, I think that's a mistake. We should think about like the real-world incarnations of them as well. An example, Blue Cross, Highmark Blue Cross Blue Shield, one of the largest independent Blue Cross Blue Shields, is opening up 120 stores across Pennsylvania to sell Blue Cross insurance. Main streets in every city in Pennsylvania, there's going to be a Blue Cross store to sell insurance. So there could be like real-life incarnations. I suspect a lot of the public exchanges are going to realize that they actually have to have some real-life existence as well. It can't just be on the computer. So is it clicks or bricks, right? What type of tools are available? Is there decision support available to help people make the choices that they have to make? What type of education is available through the exchange to help people learn about these different products, learn about these different types of insurance? Is it a year-round experience, or is it a purchasing experience only? Again, to use an example, eHealth is a place where someone would go to buy individual insurance. You probably never go back there unless you want to buy insurance again. The idea is that you make the purchase and that's it. If you went to Amazon, you bought a book and never wanted to buy another book, you'd never go back to Amazon. It's only about a purchase experience. Or is it beyond the purchase experience? Is it actually kind of a place year-round where a person can kind of manage their maybe insurance products? That would be more like your 401k portals. Imagine your own personal 401k portals. What type of support is available? Administrative support. actually processing all these transactions, billing. Is the billing run through the exchange, or is it somehow outside the exchange? Is it, do you buy it? Do you buy the insurance here and then have someone else bill you over time? And is there personal support? Is there personal consumer support? Last question is where the money's coming from. Is the money coming from person's paycheck? Again, eHealth, good example. Again, write the check, right? You put your credit card in. Comes from person's wallet, from the person's assets. Is it defined contribution coming from a company, coming from money that a company is going to allocate into, an allocation that an employee can spend? Is it coming from subsidies? That's, on the public exchange. Is it coming from payroll deductions? And so I think if you think about the different exchanges that you see and use this and kind of circle it, like for instance, if you were to circle Bright Choices, this is kind of what it would look like. And it's a way to start to differentiate these exchanges. Actually, a new one that we're adding, that was a question that came from the back of the room earlier today in the money area, is the funding of the health insurance products. Is it fully insured? Is it insurance? Is it self-funded? Or is it some type of hybrid? And you'll see some exchanges that are only going to be fully insured. It's not self-insured plans. Aon Hewitt's exchange, even though it's actually focused on very large companies, is entirely fully insured. The choice is made to make that fully insured. Other exchanges will be all self-funded. Bright Choice is actually both fully insured and self-funded products. And so that's another way to look at these different exchanges. So what's it all about? Somebody said to me once he thinks that exchanges are a solution in search of a problem, right? I don't believe that, given where I sit, but I think it's a valid question. What is the problem that exchanges are trying to solve, or these stores? The problem is pretty well encapsulated in what each of you do kind of every year, right? Every year as insurance costs increase, you're pretty much stuck with one of these three choices. In fact, it really strikes me that the surveys that the consultants do every year about what is going to happen in benefits next year, it's always like one of these three things, right? Either a company's going to pass more cost onto the employee, either the company's going to cut or decrease their benefits, or the company's going to spend more on benefits. You realize that none of these is actually a long-term solution in any way, right? Every one of these runs off a cliff. You can only pass more costs onto the employees until people say, that's it, I'm fed up, I'm done, I can't afford it anymore. Nowadays a shocking number of people decline coverage at work without coverage elsewhere. In fact, of the 45 million or so people who are expected to get insurance because of healthcare reform, 15 million of them have coverage available today at their place of work and decline it without coverage elsewhere. Contributions is too much for them. Well, every year we see, in fact, I remember early on, 5 years ago, sitting with executives at United Healthcare who said that their number one biggest problem is increasing waivers. That's their number one biggest problem, is that every year they write more companies and they get less members because more and more people are saying, nope, I'm fed up, I'm not going to have insurance. So you can only pass more cost on to a point where it eats up someone's whole paycheck. You can only cut and decrease your benefits until a time that you don't offer benefits at all. It's all gone, right? In 1989, 86% of companies with less than 25 employees offered health insurance to their workers. In 2012, 46% offer health insurance to their workers. That's a stunning change. It really is like a shocking change that's happened in the space of just the last 20 years, and it has accelerated in the last few years. And obviously, you can only spend more on benefits until that's it, until you've spent all your money on benefits. So obviously, none of these solutions, and these are the only things anyone ever does, right, is a long term. So one of the things that we thought about when we thought about creating a different way, is there, I talk about in politics a third way. Is there a different way here that is different from those things? And the core problem that exchanges try to solve is that the way in which we buy benefits in this country, buy health insurance country, is kind of intrinsically broken. If you think about almost like a class on insurance, on what is insurance about and how to purchase insurance. Insurance is really about finding the right coverage for a very specific set of risks and needs. So yourself, when you shop for car insurance, you have needs, you have risks that you want to protect yourself against. You buy car insurance that matches those. As a company buys insurance for its liabilities, it thinks about what are its liabilities, what are its employment liabilities, maybe it has vans that drive around the city, so it has liabilities there. What are the assets it wants to protect? It very specifically thinks about what are the needs it has and what are the risks that it wants to protect itself against. That's not really how we buy health insurance and dental insurance and life insurance, is it, right? Because the specific risks and needs are the individual needs. It's not the health of the company. It's not the teeth of the company. It's not the life of the company. That if you have an organization with 20 people or 200 people or 20,000 people, each one of those individuals has their own very specific kind of needs, the very specific risks. We'll choose to cover them in a different way. And so making the decision at this kind of higher level it simply doesn't make any sense from a pure insurance perspective. It's impossible. In fact, the best case scenario is what a company does is do the average. It's like, let's take everyone's risks and let's average it. And let's have an average coverage for everyone's risks. You've overcovered half the people and you've undercovered half the people. Now, what companies typically do, actually, if you look at what people buy with their own money, when people assess their needs, and you look at what companies make, the purchases companies make, they actually buy about the 83rd percentile. They overinsure about 83% of people if they were given like the money themselves to make a choice, which, by the way, kind of makes sense, right? You know, when a company sits down and makes decisions about its insurance, it thinks about the people who are the most at risk, right? People making decisions are typically people who themselves have more risks in their life. And so they're making decisions that are not right for the bulk of the population. And it goes far beyond health insurance. Imagine two companies that sit side by side in that office building over there, and one of them offers dental insurance and the other one doesn't offer dental insurance. Does that mean the company doesn't offer dental insurance, none of the employees need dental care? Does it mean that they have titanium teeth? Of course, it doesn't mean anything like that. Because the decision was not about what the employees needed, right? The decision was, I can't afford dental insurance anymore, let me cut it. Or let me not pay for dental insurance because I have to pay for this life insurance. So it's really almost never about the very specific needs for each individual. So what happens is, companies and all types of organizations, they force fit their employees into the choices that they happen to have, what they happen to offer or what they don't offer. Research in this area has shown over and over again that it creates significant inefficiencies in every type of insurance, health insurance being the most inefficient. What people would spend their own money on is covering their own risks is just dramatically different than what companies would choose. And that creates a deadweight loss that's never recovered in the system. All those people who are overinsured, who don't value the insurance, they don't use the insurance, it's not valuable to them. And again, thinking about it from maybe a retirement perspective is a good way to kind of think about it. You wouldn't imagine that each one of the people who work for you would have the exact same retirement for you. You wouldn't imagine that each one of them would drive the exact same car, would wear the same shirts, would live in the same house. So why do they need the same insurance? They obviously don't. They need different insurance. So imagine a better way. And this is what exchanges are all about, of all types of exchanges. What if an organization, an employer, made a single strategic decision? How much money to allocate for benefits, literally did it over a 3 to 5 year plan, like a long-term spending plan, the way organizations do for all the other parts of their business, right? And then give the employees access to these dollars, plug the employees into a store, that's the exchange part, right? Plug employees into a store, imagine this robust online store where there's lots of different options, where people get support, and technology really shows them how to combine different coverages to best meet their very specific needs, really helps them make decisions for themselves and their family, giving them personalized recommendations in a kind of supported environment, and then handles all the administration. This is what an exchange can do. The role of the employer starts to look a lot more like your role in the retirement area. You create a playing field for which people can satisfy kind of their own needs. And you give them assets, you give them money to help them do that, and they do it themselves. The benefits to the employer, typically companies save money. They save money because there's this inefficiency. There's this huge gap between the choices that companies make and the choices that people make if they're driving their own dollars. I mean, in some ways, frankly, this stuff is like so self-evident, right? It's the basis of a free market economy, is that people make value judgments on a cost and benefit and choose what's right for them. Companies get a predictable budget for the future. They're now not beholden to a jack-in-a-box rate increase. And administrative tasks are eliminated. And so a lot of the administration kind of goes away. Companies can stop having benefits and health insurance is a big part of what they do. They can do the things that are important to the organization. Employees typically save money themselves too. They figure out ways to, Americans are great consumers. When there's lots of choices, and lots of different ways to kind of combine, coverage to meet your specific needs. Most employees figure out ways to reduce their payroll deductions, to find ways that fit their own personal needs better. By the way, the employees who spend more get more, right? I mean, which is kind of the American way, right? If you need more and you want to spend your money on more things, you actually get more. You get more coverage, you get more insurance, you get more money in your HSA, whatever it might be, right? The employee who drives to work in the Mercedes doesn't ask their colleagues to pay for it, right? And is not upset about the Mercedes. They like it. That's where they spent their money. And so people are happy regardless. So people are in control now and they're happy. And for the first time, they kind of understand and appreciate health insurance and their benefits in a way that they never did before, because they're the ones kind of spending the money. It's kind of they're in control. And we've definitely seen now, 5 years in, that people get very involved in their health care and start to become, kind of masters of this. I mean, they start to know more about these insurance than any, one of us ever did, even benefits professionals, because they really try to figure it out themselves. Yes, go ahead. Sure. So I'll answer that in a couple ways. First of all, let me repeat the question. The question was, what about employees who don't want to be engaged in a buying process and don't want to be part of this decision for themselves? Because there are certainly employees who kind of jump in with kind of both feet, and others who take a more laissez-faire attitude. So I'll answer that question in two ways. First of all, real-life experience. It was absolutely a concern 5 years ago. We're like, what about the people who are just not going to go log on? What about the people who are going to be confused? Our real-life experience has been, it's such a dramatic paradigm shift for a person when you say to them, the company is now going to allocate to you, going to give you $5,000, $10,000. It's a lot of money, right? And here are your choices. It's just so different than what we've done in the past that the vast majority of employees kind of jump right in. In fact, this is the single biggest purchasing decision that most people will make in a year. And think about, every employee thinks about their next dishwasher, thinks about their next plasma TV in a more structured way than they do today in benefits. So as soon as you kind of turn it around and make sure they understand, so it's a big part of communication. It's a big part of really telling them that they're empowered, that this really is about your needs and your family's needs. We have found that the vast majority of employees, 98% of employees who use Bright Choices, we processed over 125,000 transactions, all different types of companies, from unskilled, mildly skilled labor, populations that speak a third, English is not their native language, all the way to kind of the whitest white collar, go on to the Bright Choices system and make their choices. So first part. Second is you have to make it easy for them, right? And so the technology has to be really easy and has to be accessible. So it's not about unfolding this big piece of paper with a whole bunch of graphs and charts, right? Answer a few questions, get a recommendation, make your choices, make it easy for them. So there's a lot of things you can kind of do on the let's call it the front end, right, to kind of engage employees and get them to do it. And then there's fail-safe. Fail-safe is you have default elections, right? People just just don't do anything. You default people into choices. And so there's always a way, there's never a case where people can fall through the cracks if the organization makes a decision to say people can't fall through the cracks. Frankly, some of our clients don't make that decision. Some of our clients say, you know what, if the person isn't going to go use that money, it's not my job to protect them. Some clients do. They say, no, we're going to have to default people into coverage. That's fine, great. So put that in the system. You don't make choices, you default it into coverage. And so there's really a legion of ways you can protect people.
I'll just jump in just to say decision support system, a sophisticated one, really helps, I think, engage employees. It makes it that much easier for them to engage in the process, which is one slide in my slide deck where I talk about decision support generally, and it's incorporated into Liaison's business model, for example. And I'm not an IT guy. They built a fantastic system, but to me, decision support is key in that process, and I have found is a significant driver to engaging folks.
Yeah, it's actually a lot of times we think the most important thing we do is decision support. All the rest of this stuff is really like the plumbing around the decision support, making sure that like the transactions actually get processed. That's important too, but that's really plumbing. That the heart of what we do is kind of educate people and empower people and kind of, and give them this easy way. Answer a few questions that take you 15 minutes, get a recommendation, make your choices. If you like it, just keep it. Go ahead.
So, what do you do about the situation where the customer, employee, whatever you want to call them, actually don't make rational choices on their own behalf? And that often is the case. And so you use this metaphor with the retirement savings plan. Where I work, we have a defined contribution plan and no pension.
Mm-hmm.
And in a review of our retirement savings plan, tax advantage that you probably
understand it
can't
well.
get that anywhere else. We have highly educated people.
Right.
Of course, at that time about 600 or 700 employees. Only about a little bit less than 50% of the people made any elective contributions whatsoever, and only about 15% of the people made it maxed out to the limit. And they're making more, it's not like a 7-Eleven,
Sure.
they're making more than average. They could well afford the $17,000 or $2,200,000 put. I can't imagine what they're going to do in retirement, and yet maybe they want to buy a boat for today.
It's a huge paradox that we as an economy have empowered people in what is by far the most complicated part of benefits to make their own decisions. I mean, you think about a 33-year-old employee, right, who the things that they have to try to figure out and understand to plan for their retirement 32 years from now. They have to understand compounding interest. They have to understand investment strategies. They have to understand how you spend down money. $1 million sounds like a lot of money. Not if you're going to live on it for 30 years, it's not so much money. They have to understand so much to engage in a retirement, and we cavalierly do that. It is so much easier for people to decide on what health insurance they need tomorrow. I mean, literally it is tomorrow. Please, I'll answer the question. And so what we have found, I mean, real life experience, we absolutely were concerned about that. Real life experience. First of all, you put products in the marketplace that are good. They aren't bad choices. They're all health insurance. 60% actuarial value is the least expensive plan. Least expensive plan there. So let's talk about the mistakes. If you make a mistake in your retirement planning, you end up with half the money that you need, in retirement, or a third of the money that you need in retirement. That's a stunning mistake. That's a mistake that you'll never kind of recover from. What are the mistakes people can make in health insurance? Well, they probably should have had a plan that had a $1,000 deductible, but they have a plan that has a $2,000 deductible. I mean, seriously, there's such a protected environment. It's almost like, imagine like guardrails. There's these guardrails around things like health insurance and dental insurance and life insurance, disability insurance, that are so much bigger guardrails than there are around retirement, and we have no guardrails around retirement, right? If you just want to forget about it, you just forget about it. So you do things like we talked about. You default people into elections who just opt out, who just say, you know what, I'm not going to use the system. And so you just default people into choices that are reasonable choices. You have products in the store that are all good. You don't have like illusory insurance kind of in the store. And again, a good example would be kind of the metal levels. You have, the least expensive plan is the plan that has 60% actuarial value. And so it's certainly possible that someone would have been better with an 80% plan, but actually got a 60% plan. That's not such a dramatic mistake. And by the way, that mistake can be corrected the next year, because these decisions are decisions that you get a chance to kind of think about it again. So again, real life experience. We find when people make these choices, if you look 2 years later, 90% of them have actually stayed in the plans that they've chosen, which means they feel like they made the right choice. We ask them questions about satisfaction. Ask them how they're satisfied about these plans, and they show a very high level of satisfaction. So you do have to create protections. You have to create protections that protect people, but trust people, because they make far bigger decisions than should their deductible be $1,000 or $2,000 in their life every day that we don't protect them with at all.
Yeah, but let me just say this. I only use the retirement metaphor because you brought
It's a good
it
one.
up. But nobody buys insurance ever having to expect to take advantage of it, right? So
that's not true of health insurance. That's absolutely not true of health insurance. That's undeniably not true of health insurance.
Most people want to stay healthy.
But everyone knows they're going to use health insurance. It's a good point. That's why you don't buy.
Have to take advantage of it.
but everyone knows they're going to use health insurance. And people buy dental insurance. It's actually not true. I mean, people buy dental insurance all the time expecting to use dental insurance. People buy vision insurance expecting to use vision insurance. People buy disability insurance because they know that there's a chance they become disabled. There's a chance they buy short-term disability insurance because they know they're going to have a baby in a couple of years. I mean, the types of insurance we're talking about are actually not the hurricane insurance. It's not the type of insurance, like I bought car insurance, I hope I never, ever use my car insurance. The types of insurance we're talking about are actually things that are used commonly all the time. I would agree with you that types of insurance that are very unusual is more difficult for people to make purchasing decisions on.
Sorry, we only have a few minutes left. You guys can continue that discussion later offline, but yeah, we just got a few minutes. If you want to just give any final highlights, Alan, from the kind of remaining slides.
I think that the key is that you have to have, when you're looking at moving into an exchange, it has to be a very holistic experience that solves kind of all the needs you have, not just a part. I think what you see out there, and frankly, I think the public exchange might fall into some of this as well. Having, again, done this for a couple thousand companies, the needs are very robust. And so the centerpiece is the technology, give example, our technology, and just to think about all the things that are around that. Again, this just happens to be what we do, but I would suggest that any exchange that you use, anything you look at needs to do all these things. First, there's the area of funding. Think about it as chronologically. First, trying to decide how much money should you allocate? What's the purchasing power of those dollars? What's a good amount of money? What's the amount of money that people won't be able to afford the right insurance? You want to be able to put incentive programs in, incent people to do things like take a health risk assessment, incent people to do things like keep their BMI at a certain level, kind of put it all together. And then you have to have a technology that handles all that, right? So it's easy to say, again, very often would commonly kind of say in maybe shorthand, say, allocate $10,000 to your own employees and let them go shop, right? But that might not be the right number, and it might be different, right? You might want to allocate different amounts of money for people who choose single insurance than people who choose family medical insurance. You might want to allocate certain dollars and earmark certain dollars only for medical insurance, only for health insurance, and then you have to decide on whether you want to let people roll dollars over into other things, like roll dollars into their health savings account, for instance. So this whole area of funding requires a fair amount of thought and scenarios, and also some pretty significant technology behind it to kind of manage all that funding. The next step is the benefit store, right? You need to have a good store full of benefits, right? I'll show my, kind of my age in that, when I was in school, I learned all about those stores in the Soviet Union, right? that didn't have anything on their shelves. It would only be like one pair of jeans, that's it, right? I mean, you don't want to have a store like that. You want to have a big store that's robust, that has all different things that will meet people's needs. And actually, it's a fair amount of analysis that goes behind that, right? What types of insurance should you have? What different choices? How many choices is enough? It's going to be different for different geographies. In geographies where kind of everything is a PPO, you probably need less choices than in geographies where there's HMOs, there's gated HMOs, there's point-of-service plans, there's PPOs, there's small networks, there's hospital-oriented networks, there's ACOs here, there's narrow networks there, there's HSA qualified plans. You probably need more choices in an area like that. And so you need to have a big, robust benefit store, Fortune 500-like benefits. The next step is you need the employees. The consumer needs to have a significant level of service. You have to have technology that's going to engage them and help them make the choices that are right for them and really help support them through the whole process and going forward. You have to have a call center. You have to have, it can't just be about the technology. There has to be someone that someone could talk to. These are big decisions. And then a lot of the communication has to be personalized. So it can't just be online. It has to be on paper. It has to be, maybe payroll stuffers, posters on the walls, and all that has to come from the same system, right? It has to come from the same, kind of exchange area. And then the service on the administrative side to the organization or to the employer. You're talking about, access to reports and analytics to see exactly what's happened, all that deep benefits administration. Once people make purchases on some system, on some exchange, actually insurance has to be transacted, right? These transactions have to get to insurance companies in timely fashions, right? The transaction has to be correct. The billing has to be handled. So there's bills that are going to be resulted from this. There's payroll deductions that are going to result from this. So there's a lot of administration and plumbing that goes on behind this, and then it really helps to have some type of service team behind that as well. So again, it's not just a piece of technology; it's also some kind of personal support. So what I would suggest is, as you look at and think about exchanges, and I think almost every one of these things applies to the public exchange as well, at least to shop. If you take the individual exchange out, you just kind of drop off the employer side and the funding side. Imagine like the green and the pinkish. Like on the left-hand side is really the company, and the right-hand side, as I'm looking at it, is the employee or consumer service. If you imagine the individual public exchange, just kind of cut off the employer side, they still have to provide all those things on the right. If you imagine SHOP, the public exchange, they still have to do all these things. They have to manage all the funding that a company wants to deliver. They keep talking about defined contribution, but actually doing that's somewhat of a challenge. So as you look at different exchanges, it's another maybe rubric you can use to kind of compare them and see if they're doing what it is right, what your organization needs. So I'll just kind of get to the end, and we'll kind of open it up for some final questions.
First off, apologies in advance to everyone, both here in the room and especially those on the phone. There were a lot of questions posed that we simply did not have time to get to. For those of you on the phone, feel free to, like I said earlier, email your questions directly to our speakers, and we'll do our best to get back to you. I know Chris has just a final couple comments to close things out, and then we're going to have to wrap this up, and we'll stick around afterward for more questions.
Yeah, I just want to give a closing thought, and Alan really touched on it. What's interesting, if you take a step back to connect both of these dots, i.e. the public exchange, what we discussed, and now the private exchange, which we just discussed, is really the issues and the ideas and the components that go into this marketplace that Alan just described were intended to go into effect in the public exchange. So there's a question of whether the public exchange will be able to incorporate all of those components. But at the end of the day, for all intents and purposes, that's what we in Congress wanted to do in creating this public exchange mechanism. Now, again, there's these entities that are existing in the private marketplace which already offer these type of components. So I say that to say, if you're a small employer in the fully insured market, there are options for you. You have the SHOP exchange, you have private exchanges. If you're a large employer, you generally don't have the public exchange available to you, but you have private exchanges in the fully insured market. And to the question that Alan and I got earlier, in my opinion, large employers who self-insure can utilize private exchanges as a tool to reduce healthcare costs. One would argue that a private exchange, or at least the exchange concept, allows the employee to be a better consumer, therefore the self-insured employer is spending less. The employee may be getting into a higher deductible health plan or utilizing less. If that's the case, a self-insured employer is coming up with less money out of their general assets to cover that claim. I'm not saying private exchanges is right for every self-insured large employer, but there are self-insured employers who, A, already take advantage of private exchanges, and I believe can because of the tools and the components that are available in a private exchange, which again goes back to in the fully insured market for small and individual, if those components are there, you arguably do make the consumers better educated, they make better decisions, which then the theory is you have more affordable coverage in the long term. So with that, I just wanted to connect the dots, and I don't know, do we have time for one or two questions from the audience?
Any final overarching, global, important questions we want to ask our speakers? It is a few minutes after 2 Eastern Time. We need to wrap up. I want to thank our speakers for a terrific presentation. Thanks all of you for hanging on for the program today, and hope to see you back here next month. Have a wonderful holiday season, and we'll see you in January. Bye.
Thank you. Please stand by.